Thank you, Lauren. Thank you, Ron, and the Caring for Carcinoid Foundation, and also George and Pam for setting this up. I've been asked to talk briefly about neuroendocrine tumor biology, but as Dr. Fisher already gave the introduction, and Laura's nice introduction as well, I think I'll just briefly go over that. And I also want to end by talking about one of the projects that we've been lucky to have funded by the Caring for Carcinoid Foundation. I think it's important that the main motivation for our work is the challenges that anybody who's dealing with neuroendocrine tumor research is faced with, and I'll go over what those challenges are. I'll briefly give an outline of the mTOR pathway, the problems that we've encountered in treating patients with everolimus, and our project to try to overcome these obstacles. So with any cancer research, there's some fundamental challenges that researchers face. The first thing is, how do you study the disease? You need a model. You need either cell lines or an animal model to understand the basic biology of what makes the cancers grow. And then once you have this model, you have to then find ways to stop the tumor from growing. So finding the model is the first priority. I think we're all aware of the slow progress from bench to bedside for most cancer therapies, and I'll give you some examples of how in the past this has been prohibitively long, but as Lauren mentioned, in the last couple of years, we made some rapid advancements in the research for neuroendocrine tumors. Now, with any rare disease, there's few patients, so there's not much human tissue to study. That's why, as a surgeon, I think it's a priority to capture all those tissues from these very rare cases. And also, there's few patients enroll in clinical trials, so the patients that do enroll in clinical trials, it's very critical that we have them participate. So we talk about cell lines, we talk about animal models. These are the critical things that we need to understand what genes and what pathways make the neuroendocrine tumors grow. Now, once we do find these things, we're able to test new therapeutic targets, and that's how we get ideas about what we take to the clinic to try in patients. But we need these models as an entry point to the clinic. The problem with neuroendocrine tumors is there are no models, and that's why I think Lauren mentioned one of the priorities for the Caring for Carcinoid Foundation is to establish these cell lines and animal models. If you want to study these tumors today, where do you go to get the models? There's a handful of cell lines available, but as many researchers will tell you, they don't faithfully recapitulate the disease. Now, this is an example of how research was done in the past. I give this example of this drug called Gleevec, which I'm sure you've heard about in the press, which is a molecularly targeted therapy for gastrointestinal stromal tumors. It was recently approved in 2002 for the treatment of patients, but people don't realize that the first basic science studies were done in 1960. So it took over four decades to get from the bench side to the clinic. Obviously, this is not acceptable now. And as you'll see, through a multi-pronged approach, we're attacking neuroendocrine tumors in a more rapid pace. And this is another roadblock that we've had in other rare diseases, such as sarcomas, where there are too few patients that, although people had great ideas for clinical trials, oftentimes these trials were closed due to poor patient accrual. As you'll hear from Dr. Kuntz and Dr. Bergslund, there are many clinical trials that are up and active for neuroendocrine tumors, and thankfully there are patients such as you that are participating. So these are the challenges. So if you're faced with these challenges, how on earth do you make a dent in this disease? And I want to tell you about our strategy about addressing some of these challenges and how our approach to make some advances in neuroendocrine tumor biology. Now first, a little this is my one slide on the biology. Over the last few years, there's been increasing evidence that this pathway called the mTOR pathway is a critical driver of neuroendocrine tumor growth. As Lauren mentioned, in 2011, a seminal paper was published that showed everolimus, which is a partial mTOR inhibitor, had unequivocal anti-tumor activity in a phase 3 or randomized phase 3 clinical trial. Shortly thereafter, everolimus was approved for treatment for patients with advanced pancreatic neuroendocrine tumors. However, what we find in the clinic, and you can ask the oncologist, is that although patients may initially respond to everolimus therapy, that with time, unfortunately, many patients' tumors start to grow. That is, they develop resistance to the therapy. Now, what we treat patients with once they develop resistance is unclear, and that's the main motivation of why we embarked on our studies. So what's been our approach? Well, as a surgeon, the one thing I do have access to and that I thought I could leverage to attack neuroendocrine tumors is our access to tissue. I see many of the patients out there in the audience, and thank you for not only entrusting me with doing your surgeries, but also knowing that with your tumors that have been removed, we didn't put them to waste. They're actually being studied extensively. And one thing that surgeons and people at academic medical centers can do is treat every patient's tumor as precious, a very precious commodity. Now, what we can do is at the time of surgery, we take out the tumor as part of normal surgery, and we could keep it alive in a living incubator. Now, it turns out if you take a tumor from a human and engraft it under the skin of a mouse that doesn't have an immune system, you can keep that tumor alive. As this diagram shows, you can take a small tumor from a patient, implant it into one mouse, allow it to grow up. You remove it, cut it into small pieces, and put it into 5 mice, allow those tumors to grow up, take them out, and put them into 25 mice, and so on. And then pretty soon you have this expanded living biobank of a rare human tumor, and they're alive. They grow, and you can then ask questions like, does a new treatment stop the growth, and can you image it with new imaging? And there's a bunch of questions you can ask about the basic biology of these tumors that heretofore couldn't be asked. So we took this approach several years ago. I had a patient of mine who was very motivated, and the thing he told me every day was, I just want you guys to learn from my tumor and make sure that patients that come after me benefit from what you learn from my tumor. So his tumor was one of the first that we removed. It's actually a liver metastasis from a pancreatic neuroendocrine tumor. And we engrafted into the new mice. As you can see here, we were able to pass it through several generations, and now it's been living for over like 4 years in our living incubators. And what you see in the bottom panels are the standard markers that we look for hormones for some of the neuroendocrine tumors. And we've basically been shown that these tumors do in fact look like the human tumors. They look like it under the microscope. They look like it when we stain it for the various hormones. So by all accounts, this patient's tumor looks the same as it did when it was in the patient. Now, what we can do then is use it as a living assay for new drugs. And I'm not going to go through what these bars mean, but these are molecular analyses basically showing that the mTOR pathway that we spoke about before is active in these tumors. And what we can do then is take everolimus, which is the FDA-approved inhibitor of mTOR, and showing that in fact it can inhibit the pathway. And more importantly, we've been able to test a next-generation mTOR inhibitor called INK128. Now, this is a drug that was designed by one of our collaborators at UCSF, Kayvon Choquette. And what he does is he basically looks at the chemical structures of drugs and redesigns them to make them more selective and more potent. And without going into the details of what I show up here, but essentially where you don't see a black dot is where the drug is shutting off the pathway. And trust me when I say that the INK128 is a much superior mTOR inhibitor than the currently approved everolimus. And then so you can do very basic tests. You can say, well, we have a new drug. Does it stop the tumor growth? Well, you can see here there's a basic growth curve where days are on the x-axis and volume of tumors on the y-axis. When you look at the untreated mice, they continue to grow as shown in the blue curve there. And then when you treat it with the RA day 001 is everolimus, that essentially shuts down the tumor growth. This is sort of what we see in patients. It causes the tumors to basically stop growing. It doesn't cause them to disappear, but it kind of arrests their growth. And also, as we see here, the INK128 also stops its growth. So sort of like what we see in patients, we're able to recapitulate in our model system the effect of the known and also the effects of a new inhibitor on tumor growth. Now, the problem that we talked about before is that we know that if you wait long enough, this is only a 28 days out, but what we do know is that we're finding out in our studies now that if we treat these mice for months, or sometimes even a couple months, some of the tumors start to grow again despite being treated with everolimus. And this is what we see in patients. They develop resistance. Now, what we're doing in this study that's been funded by the Caring for Carcinoid Foundation is now we're taking these resistant tumors and then treating them with the INK128 to see if we can stop the growth. It's a very simple question, but I think it has very practical relevance to patients. if this study turns out how we hope, it might serve as a foundation for treatment of patients in the future. Now, the next thing we can do, obviously, is, we talked a lot about gallium-68. Here's a gallium-68 image of a tiny little mouse. As you can see here, the mouse tumor's in the red, and these are very small tumors, and this just shows you the power of the gallium-68, how it's literally like HD color TV compared to a black and white TV, which is the standard Octria scan. Now, we're using our model as an entry point to bring the gallium-68 into UCSF, but also to ask some questions that you can't ask in patients. Like when you're a patient, you get a gallium-68, you take for granted that what you see on the gallium-68 image is what's happening in the patient. But you can't take the tumor out of the patient, measure it with a ruler, and then compare it to the gallium-68. We can do that in a mouse and see if, in fact, the size or the volume of the tumor actually does correlate with what we're seeing on the gallium-68 in real time. We can also see whether or not therapies like everolimus, modulate the image. I don't know if you're aware that the somatostatin receptors that are on these neuroendocrine tumors that the gallium is binding to are very sensitive to sugar levels in your blood and nutrient levels in your blood and just overall metabolism in your system. So we know everolimus affects metabolism, affects glucose levels in your body. It could be that those modulations of the nutritional status or the sugar levels are causing a dimming or a decrease in the gallium-68 image without affecting the volume. But we would never know that in patients. We can answer those questions in this model. So just like taking care of complex patients with neuroendocrine tumors, we require a multidisciplinary team for these studies. Keivan Shokat's the brains behind the drug design, who developed the INK molecule. Henry von Bocklin's our engineer who makes the gallium-68 isotope. Byron Hand manages the preclinical core. He's basically the mouse doctor. Emily Bergslin, as you've met, is the medical oncologist that informs us about the relevancy of our studies, and I just provide the tissue. So in summary, we're motivated by the challenges to bring these new treatments to our patients. I think we're convinced that the mTOR pathway is a promising target for neuroendocrine tumors, but we need to look at better ways to inhibit the pathway when everolimus is no longer effective. I think you've shown that relatively rapid progress has been made in neuroendocrine tumors compared to the past historical studies where it took decades to make the progress that's been made in the last 3 years in neuroendocrine tumors. And certainly this rapid progress would not be possible without support from the Caring for Carcinoma Foundation, patients like yourselves, as well as the support from the AACR. With that, thank you very much for your time.